Okay, xin chào, Professor An, Professor Lan, ladies and gentlemen. This is the only Vietnamese I know. It is my honor to be here this morning at the VRA with such a big meeting. It's in a beautiful country. We had a very nice time yesterday with the dinner. So today we do some work. Yeah? Okay, I'm here to talk about my experience with PRP. I've been using PRP for 15 years. Actually, in June, it will be 16 years. And I want to share with you things which you may not find in the journals, all right, in the research, because I think it is important as clinicians who treat patients that we also use our experience and our learning over the years with a very useful tool like PRP to know how to use it best. I will be citing some journals, but I'll be talking a lot about my own experiences as well. Firstly, I come from Singapore. This is where I work. I don't work in the whole building. I only work in the place where the arrow shows. That's my clinic. It's called Camden Medical Center. Now, if you do a search in PubMed for PRP, and let's say you take the last 23 years from the year 2000, you'll find that there's nearly 3,000 results. And if you look at the number of studies done since 2010, in the last 13 years, it's really gone very high. There are almost like 600 to 800 new published studies every year. In the year 2010, the New York Times actually wrote an article saying that PRP may not work, but since then, you can see so much research has occurred, and without a doubt, I can stand here and say that it works, but you have to use it correctly. My favorite definition of PRP, or platelet-rich plasma, is that it is a biological product defined as a portion of the plasma fraction of autologous blood with a platelet concentration above the baseline. So this, to me, is a very nice general definition, and it actually reflects the variety of ways PRP can be prepared and used. Why do we use PRP? In 3 words, it is useful, it is easy, and it is safe. So platelet growth factors support all the phases of wound healing and repair, from inflammation to proliferation to remodeling. With all the current commercial kits, and I'll show you the one I use in several slides later, there is a very simple method to prepare most of these. There are no known adverse effects in contrast to maybe corticosteroids as an injection, where we know that there could be long-term and some short-term effects. It is important to understand that PRP is not one single thing. And as I said earlier, depending on how you prepare it, it can be in various different forms. So one of the important differentiations, I would just want to highlight WBC, the white blood cell content of PRP. In the literature, if you look at maybe the first few studies of PRP, nobody talks about white cell. We all just say PRP, PRP, as if it is just one single thing. But if you look at the current literature, most studies would actually define whether they increase the white cell concentration above the plasma concentration, above your blood concentration, or whether they decreased it. So you will see the term leukocyte-rich and leukocyte-poor. Leukocyte-rich means the content, the white cell content of PRP is higher than your blood content, higher than your blood concentration. Leukocyte-poor means that it is lower than your blood concentration. So this is just a simple differentiation between 2 different versions of PRP. But the more you use PRP, the more you realize that this is even a little bit too simple, right? So it is actually a very, you can vary the PRP to almost infinite ways to use it to your advantage. Even knowing where to inject, how to inject, where exactly, how often do you inject, all these are variations which can affect the outcomes of PRP. Now, there are 3 very important things I've learned over the years, and I just want to summarize these 3 very important things because PRP is not a magic bullet. right? So to understand PRP, the first thing is that it is not a structural intervention. It is not like surgery. With surgery, you can stitch something, you can remove something, you can trim something. With PRP, all you are doing is creating an environment around the injury which is very rich in growth factors. The third thing, which is probably the most important, is that do not stop your other normal measures if you are doing PRP. You add on PRP to what you would normally do. If in osteoarthritis, you tell the patient you need to lose weight, yes, you do need to lose weight. If you need to reduce impact, you still need to reduce impact, and then you add on the PRP to give you a better advantage to help the patient. In the year 2023, these are the things which PRP is most commonly used for. Intra-articular, we use it for osteoarthritis, for synovitis, for chondral lesions, for chronic tendinopathy, for acute muscle tears, for acute ligament tears, in some cases chronic ones as well. And then there are a lot of other uses where people have found use for over the years, for example in prolotherapy, in hydrodissection, in frozen shoulder. So let's just do PRP for osteoarthritis, which is probably the most common use of PRP in the world today. And if you look at the literature, the evidence supporting osteoarthritis and PRP, there are actually over 40 meta-analyses now of randomized controlled trials, and in fact close to 50. And in general, I would say that the majority of them do support the use of PRP. They are favorable towards PRP compared to hyaluronic acid, compared to maybe placebos and steroids. Since 2020, there are two important consensus statements. One called the GRIP consensus, which is French-speaking rheumatology society in Europe, and the ASCA conference consensus, which is probably one of the biggest knee societies in Europe. And I will actually encourage you to read the ASCA consensus because it actually gathers a lot of the important studies. It answers a lot of important questions about PRP with evidence and with expert opinions. The reviews continue to come, the meta-analysis continue, and this is one of the most recent ones in the American Journal of Sports Medicine, and it talks about PRP in comparison to hyaluronic acid, corticosteroid, and PRGF, which stands for plasma-rich in growth factors. And it says that PRP has improved outcomes compared to all these other injections at a minimum of 6-month follow-up. So the reviews keep coming, and nowadays we see more positive reviews as the studies themselves are better quality and the kind of PRP use is more orientated towards osteoarthritis. This is an important study, and I want to highlight this because in 2016, this was the first study which actually differentiated the kind of PRP to be used in osteoarthritis. It was done by Dr. Jonathan Ribot at Cornell University, and it shows that leukocyte-poor PRP, where you reduce the number of leukocytes, has better outcomes than leukocyte-rich for osteoarthritis. All right, and this is important because there are some studies now which suggest that leukocyte-rich could have the same outcome, but most studies acknowledge that with leukocyte-rich, you will get increased soreness when you first inject. Right? So I use leukocyte-poor. This is the system I use, and it's a very simple preparation, and we concentrate the PRP to about maybe 1.7 to 2.2 times of the platelet concentration. So if you go into the literature on PRP, you will also find that there are now meta-analysis, there are randomized controlled trials which favor the use of PRP combined with hyaluronic acid over PRP or hyaluronic acid alone. This is a study from 2018, which is a RCT, and it shows, and this product called Cellular Matrix, it uses hyaluronic acid combined with PRP in the same tube. You spin the whole thing together and you just inject everything. And this was a study which compared this against hyaluronic acid alone and shows that the outcomes were better. There are two other meta-analyses you can find. one which compares PRP plus HA against PRP alone, and another which compares PRP plus HA against HA alone. And they both show favorability of PRP and HA. So another thing I want to emphasize that for osteoarthritis, when you use PRP intra-articular, make sure the needle really goes intra-articular. Make sure the needle does not go into the fat pad. And why this is so is because PRP has got essentially a short period for it to activate, and it activates in the location where you put it. If you put it in the fat pad, it activates in the fat pad and it doesn't go into the rest of the joint. If you put it in the joint, then it goes all around the joint, and it can target the synovium and it can target the intra-articular surface. I personally like to use the lateral and supralateral suprapatellar approach for my injections. And I always like to use ultrasound, but this is your own preference and practice. This is the approach I normally take, and you can see on the video, we can see the suprapatellar pouch with ultrasound guidance. What if there's still pain after you do the intra-articular PRP? And this is where I just need to emphasize in osteoarthritis that pain does not only come from inside the joint. And this sometimes, to me, explains why some studies don't work if they do not look at extra-articular causes of pain. So the pain can come from anywhere around the joint, outside of the joint cavity. It can come from ligaments, it can come from tendon insertions, and it can even be neuropathic. This is a whole lecture by itself, so I'm not going to talk anymore about this, but I just want to say that you must pay attention to pain which comes from outside of the joint as well. Now, so this is a summary of what I do with the osteoarthritic joints. I treat most of them similarly. Any synovial joint, I think you could use PRP on if there's osteoarthritis. Our goal, I must emphasize, is not to cure. For osteoarthritis, we are just trying to, what we call, hold the line, which means that we want to limit the damage, we want to limit the progression of osteoarthritis. And a lot of patients come to think that they can do PRP in place of a knee replacement, and the answer is no. If we catch them early, we can try to stop the progression and stop them for years. I combine it with hyaluronic acid about 3/4 of the time now. Now for tendinopathy, it gets a bit more complicated because you will see in the literature that there's always mixed results. And the reason for that is because tendon pathologies can be mixed. It can be chronic tendinopathy, it can be an acute tear, it can be tenosynovitis, for example. And then if you take, on the other side, the PRP you use, that can also be mixed. So if you take a mixed condition with a mixed cure, you will get a mixed result. All right? So we need to be more specific, and I'm going to talk a little bit about chronic tendinopathy because this is the most common condition I see in tendons. To help chronic tendinopathy to heal, you need to induce an acute phase so that you induce a robust healing response again, right? And we use PRP for that. Before we had PRP, we were using peppering of the tendon. We would take a needle and we would poke the tendon to try to induce an acute phase. With PRP, we now can concentrate the PRP, high platelet count in low volume of plasma, and pepper the same thing. As we pepper, we inject a little bit of PRP at a time. This is how I concentrate with the system I use. After we spin, before we resuspend the platelets, we remove a portion of the platelet-poor plasma, and then we use whatever remains to pepper the tendon. I usually pepper the tendon under ultrasound guidance. This is a little study I did about 10 years ago, where we used this method using the Region Lab system, and about 66% of the patients experience a post-procedure pain lasting less than 3 days, and 88% experience a post-procedure pain lasting less than 1 week. The reason for this is because we induce an acute phase again, right? And this method of treating PRP of tendons was again validated in a meta-analysis by Dr. Jane Fitzpatrick from Australia. And with a meta-analysis of 18 studies, she showed that there's strong evidence that leukocyte-rich PRP improves outcomes in tendinopathy. The technique has to involve peppering. You can use a bit of local anesthesia, but try to keep it outside of the tendon sheath. And we do this under ultrasound guidance for better accuracy. There's also a more recent study which shows that leukocyte-rich PRP has a better stimulating effect on tenocytes. For ligaments, PRP in acute ligament tears, there's no meta-analysis which is exclusive to PRP for ligament tears. So there's actually some gaps in knowledge here. There are few studies, but if anyone is interested in researching PRP, this is an area where there's a lot of open questions. For muscles, PRP used for muscles, yes, there are several targets for muscle tears, and but again, there are not that many studies. This is one meta-analysis which looks at just 5 studies, which shows that for grade 1 to 2 muscle strains, there can be an earlier return to sports. For hamstrings, sometimes the evidence is a bit weaker. There is a question in muscle tears whether we should use PRP or PPP, because PRP tends to favor proliferation of the myoblasts, PPP tends to favor differentiation. But there's no clinical trial now for PPP on muscle tears, platelet-poor plasma. There's only, in the literature, there's only one case study reported. So again, this is an open area for anyone interested in researching muscle tears and PPP. What about frozen shoulder? So this is, you'll see that I said since 2019, only I started using PRP for frozen shoulder. And that's because there were only studies on frozen shoulder and PRP published since then. So right now, in fact, in this year, very recently, there was a systemic review which shows that PRP for frozen shoulder is at least equivalent to corticosteroid. We know frozen shoulder is poorly understood. We don't quite know the mechanism why PRP could work. Perhaps it's the same as for any other injury. But right now what I'm doing is leukocyte-poor PRP, which means that I really try to reduce the number of platelets in what I inject. Reduce the number of white cells in what I inject. And the version I use is this particular tube where it reduces it by almost 90%. Right? And we find that it is effective for pain relief. It does seem to make the stiffness a little milder as well. But I think, again, this is an area which needs more research. Now, a question I always had was, does the PRP stay where you put it? Right? And of course, if you put it in the joint, in the intra-articular space, it stays right there because it is a closed space. In a tendon, we know that PRP can move away from the tendon site which you inject. This study shows that, in fact, in 98% of cases, almost 100%, the PRP will move more than 2 centimeters away from the point you inject. Right? In a ligament, if there's a tear, how do you make the PRP stay in the tear? Right? If it's a gap. Right? So this is a picture showing an ATFL with a tear, with a full thickness tear and a gap. And if we try to put PRP in there, would it stay right there? So to answer these questions, we should revise PRP activation. I just want to highlight that we could either do not put an activator, or the fastest way to activate platelets is by putting thrombin, which releases all the growth factors, it dumps them all out very fast, and it coagulates the platelet. This is just the coagulation cascade. It's just a revision. I just want to emphasize that thrombin is right at the last stage. So if we add thrombin to your PRP, it becomes solid very fast. And then we call it platelet-rich fibrin, because the fibrinogen has been converted to fibrin. And having platelet-rich fibrin has an advantage. We will create a clot, we will create a temporary extracellular matrix, which will ultimately result in a permanent extracellular matrix, and healing occurs faster. It is used already in dentistry and orthopedics as an open procedure. But over the last 4 years, I actually asked myself this question, whether we could make this clot inside the body without opening, without surgery. And so I want to introduce the procedure which I've been doing the last 4 years, called a PRP with autologous thrombin, or PAT, which happens to be my name. This is a technique which I've been using a lot in the last 4 years for more severe tears. So this is the first patient I did, one of the first patients. He was a boxer and he had a tear in his common extensor origin at the elbow. We did the PAT injection here, and in 8 weeks we could see definitely that he was healed. This is what we did for ATFL tendons, the ligaments in the ankle tears, similar thing, right? And what we did then was we collected the results of the first 75 patients I did between 2020 and 2022. These were all patients with high-grade tears, high-grade ligament and high-grade tendon tears, which can be seen on ultrasound. And we scattergrammed, we plotted the pain against the time, and we got an average line, and we decided to find the 50% point at which pain reduction occurred. This is an example for tennis elbow. In summary, with this technique, we achieve about 50% pain reduction in an average of 5 to 6 weeks, and for ligaments it was about 6 to 8 weeks. Right? And the PAT results, these results were comparable to PRP for lower grade ligaments and tears. This was a series I did 10 years ago, and we found the results were quite comparable. Now, just to end off, I just want to show a use of PRP which I encountered. So, you know, this is a road accident. I know in Vietnam you drive very slow, so it will not occur in Vietnam. You come to Singapore, please be careful when you cross the road because drivers drive very fast in the city. All right, so this lady, this was 1 year ago before I saw her. She's 50 years old, she's an accountant, and she had this lesion, a degloving injury, and which resulted 1 year later in this seroma over the gluteus maximus. And when she saw me, I tried aspirating it for 8 times, and it kept coming back, and it was painful, and she was unable to sit for more than half an hour. So here's the seroma on ultrasound, and this is what we did. She finally agreed to try a new method, so we injected the local anesthesia. Right? The seroma has got epithelium all over the inner lining, and then we took the needle and we abraded. We disturbed the inner lining under local anesthesia because it's very painful if you don't have local anesthesia. And then we aspirated everything, which included the serous content, any bleeding, and the local anesthetic. And then we injected the PAT injection, the PRP with ATS injection. And after this, at 3 weeks, there was no recurrence. At 3 months, no recurrence. And I last saw her 5.5 months after, and there was still no recurrence. So this was a very useful technique for dealing with this problem. So after that, with that success, the next time I encountered this sort of injury, which you will see in footballers, especially those who play the older ones, when they tear the quadriceps, and sometimes you see a big hematoma, and those who treat athletes know that if you aspirate the hematoma, it comes back very easily. All right, so with this, we tried the same thing. We aspirated, and we aspirated blood and serous fluid, and then we injected sorry, here it is, yep. And then we injected the ATS, the PAT mixture again. And again, we found that in 2 weeks, it did not come back. There was a scar forming, and there was no further recurrence. Right? So I just want to summarize now the way I do PRP. It's different for different conditions. For osteoarthritis, we go intra-articular with leukocyte poor. I would use between 4 to 9 cc's of PRP. For the hip and ankle, we use half that amount. We will do about 2 to 3 times, about 3 to 6 weeks apart. For tendinopathy, it gets really complicated. For chronic insertional tendinopathy, we use leukocyte rich with peppering, usually about 1 to 1.5 cc's. For chronic non-insertional, I will always ask myself, what's the cause? Because a lot of times it is not tendinopathy, it is actually tenosynovitis. And in that case, we want to just do hydrodissection into the sheath. We could use leukocyte poor or even PPP for that. With tendinopathy, if it's tears, we may use the PAT. And most of these, our aim is to cure. So it's just a single injection for most of them. Except for patella tendon, which is a very high loading tendon, we may use about 2 to 3 times. For ligaments, if there's a gap, I will use the PAT injection, and the remainder of the injection, whatever is left, I put it in the joint. It's a reservoir of growth factors. Right? If there's a chronic strain with laxity, I might use a prolotherapy technique using high concentration PRP. For muscle strain, I would use, depending on the time of the strain, I might use leukocyte PUR, or I might use even PPP. This is a very complicated thing. If you want, you can find me at the break and I will explain to you what I do, because it depends on the timing of the injury. For hematoma, a seroma, and I've even done it on Baker's cyst, we aspirate followed by PAT injection. For frozen shoulder, I now use leukocyte PUR in preference to cortisone, and we would usually do it between 1 to 3 times in frozen shoulder. Thank you very much.
Thank you for the excellent presentation. Now, question. Mọi người có ai có câu hỏi gì không ạ? Chỉ có 5 phút để trả lời thôi, sau đó chúng ta sẽ chuyển sang cái chương trình khác. Và các bạn cứ trả lời câu hỏi thoải mái, vì có người dịch. Các anh chị có ai có câu hỏi không ạ? Cô Hồng đâu? Có ai có câu hỏi gì không ạ? Vâng ạ, xin mời thầy Ngọc.
Có câu hỏi rất là cảm ơn ông đã có một cái bài báo cáo rất hay. Ví dụ như trong trường hợp mà bị đứt bắn phần cái gân trên gan thì chúng ta sẽ tiêm vào bao gân hay chúng ta tiêm vào trong gân?
Okay, sorry. Oops. Sorry, can I?
Vâng, nếu mà trong trường hợp mà đứt bắn phần gân trên gan thì là chúng ta sẽ tiêm vào trong cái vào bao gân hay là chúng ta tiêm vào bên trong gân ạ?
For incomplete tears, I would use the PAT injection directly into the tear. But the condition is that I must be able to see where the tear is on the ultrasound.
Hôm qua thì có một bạn hỏi tôi là đã nhờ ông hỏi một câu, tức là trong trường hợp mà ông ấy trong những trường hợp thoái hóa khớp nói chung thì người ta sẽ tiêm PRP rồi tiêm HA rồi tiêm rất nhiều thứ. Và hôm nay thì ông trình bày một cái bài mà nó có, chúng ta sẽ lưu ý là nó sẽ có rất là nhiều các cái loại mà nồng độ khác nhau, và có những loại mà nó có thể có nghèo tiểu cầu, nghèo bạch cầu vân vân, thì đấy là một cái tương đối là mới. Đấy, và có một vài cái kỹ thuật người ta có thể tiêm trong gân hoặc là tiêm bao gân vân vân, như là giáo sư Ngọc đã trình bày đã hỏi. Thì hôm qua có một bạn đã hỏi là trong cái trường hợp các cái loại trong các cái khuyến cáo guideline ASCO vân vân thì người ta có dùng các thuốc Cisara không, và người ta ví dụ như là cái glucosamine sulfat, các loại vi tinh thể này, rồi các cái loại diacetyl hay không. Thì hôm qua tôi cũng có. Thế thì nhiều bạn phiên dịch trình bày lại hỏi cho ông để ông ấy trả lời một cách rõ ràng hơn. Hôm qua tôi đã cũng có trao đổi riêng với ông rồi.
I think it is useful to use these medications as a first line. To me, PRP is a little more invasive than taking nutritional supplements. So I still do encourage patients to take them. Although to me, the glucosamine and nutritional studies, the evidence is quite variable. It is rather weak, and but if it works, I'm happy to use it on the patient. I would usually encourage them to take it anyway. And if necessary, we add on the PRP on top of that.
Vâng, tôi xin phép có một cái câu hỏi của báo viên. Vâng, cái báo cáo rất là hay ạ. Vâng, báo cáo rất hay thì chúng tôi có một cái hỏi thêm ạ. Thì cái phương pháp tiêm PRP của giáo sư vừa trình bày ấy, thì nó có một số cái kỹ thuật và cái tác động thì nó có liên quan đến cái vùng huyệt ở trong y học cổ truyền. Thì trong y học cổ truyền nó có phương pháp thủy châm, và hiện tại thì các bác sĩ học cổ truyền cũng sử dụng phương pháp thủy châm, sử dụng một số các cái loại thuốc của y học hiện đại để thủy châm vào các cái vị trí huyệt. Và hôm nay chúng ta đang nói về cái chủ đề thậm chí là các cái tổn thương sọ. Thế thì không biết là giáo sư đã muốn hỏi thêm giáo sư là liệu có thể nghiên cứu cái phương án là sử dụng cái phương pháp của giáo sư tiêm PRP này, sử dụng các cái huyệt của thủy châm của đông y để điều trị. Thì chúng tôi nghĩ đây là một cái hướng nghiên cứu phát triển rất tốt, bởi vì dựa trên hai cơ chế: một là tác dụng hàn gắn tổn thương của PRP, và thứ hai là cái tác dụng vào các cái huyệt của đông y. Thì chúng tôi rất mong muốn là giáo sư có ý kiến thêm về vấn đề này. Xin trân trọng cảm ơn ạ.
Thank you for the question. Yeah, in Singapore, I'm not familiar with the Vietnamese style of acupuncture. I'm more familiar with Chinese, but even then I'm not trained in it. But I do understand myofascial needling, which is the Western medicine version, which has about 70% concurrence with the acupuncture points in Chinese medicine. Now, I think it is useful when you look at pain and osteoarthritis from a pain model perspective, that that you can reduce symptoms. But I think it does not change the role of PRP, because I mentioned earlier, the role of PRP in osteoarthritis is to try to slow down the progression by using the growth factors and the anti-inflammatory effects of PRP from within the joint. So, and in osteoarthritis, we always have to deal with pain, and a lot of sources of pain are from outside the joint, where I actually do sometimes get my physiotherapist to use myofascial needling to help reduce the pain from the muscles, from other types of pain, neuropathic and so on. Yeah. So I think it is useful if some of them prefer TCM approach if there's pain, but I always say that PRP is added on to that to try to reduce the progression of osteoarthritis.
Okay, thank you. Thank you very much.
Thank you. Cảm ơn.
Báo cáo tiếp theo thì diễn giả không có mặt ở đây, chúng ta nghe theo hình thức online. Chúng tôi xin trân trọng xin dịch giúp tôi giới thiệu giáo sư Dennis Bogduni từ trường đại học y khoa Berlin, Germany, trình bày về cửa sổ vàng trong điều trị viêm cột sống thể trục để giúp nâng cao hiệu quả điều trị. Dạ, xin mời ông.
My name is Dennis Bogduni. I'm a rheumatologist from Germany, and I'm going to talk today about the golden treatment window in axial spondyloarthritis for better outcomes. Here you see my disclosures. I would like to start with an overall concept of spondyloarthritis as we see it right now. Here you see that we tend to classify patients within the spondyloarthritis family, depending on leading manifestations, into axial and peripheral. Axial spondyloarthritis, here we have two major members or two major stages of our disease, so non-vertebratic and radiographic axial spondyloarthritis. And among peripheral SPAs, we have rectic arthritis, psoriatic arthritis, arthritis associated with inflammatory bowel disease, and also so-called undifferentiated peripheral SPA. And as you can see, there is a substantial overlap between those two forms, because arthritis associated with IBD, for example, can also manifest with axial manifestations. The same is true also for PSA and for reactive arthritis. And today I will be focusing mostly on axial manifestations, because there we have some problems related to the diagnosis and the substantial diagnostic delay. Here you see data from Germany. They're quite recent. We published them from around 2019. And at this time point, we could see that the diagnostic delay is about 5.7 years. The median is here 2.3, meaning that we diagnose about half of the patients with axial spondyloarthritis within 2.3 years. But you can see it in both ways. On the one hand, it is certainly better than 10 years we reported about 20 years ago, but at the same time, it is still quite long, probably the longest diagnostic delay in rheumatology. And this diagnostic delay can be observed across different countries around the world. Here you see a map. The upper map is based on meta-analysis, kinetic review from Stephen Chow. And here you see data from EMA's projects. And you see that in all countries we have a couple of years of diagnostic delay. That is, of course, related mainly to rather non-specific patient presentation at the beginning of their disease. So patients are coming to us with back pain, young males and females presenting with back pain, and it might be really challenging to raise initial suspicion of axial spondyloarthritis. This is the continuum of axial spondyloarthritis. I created this graph more than 10 years ago. At this time point, it was really important for us to stress that we think that the disease starts here, always in non-radiographic state. That is true for any inflammatory disease associated with structural damage, psoriatic arthritis, rheumatoid arthritis. They all start with inflammation without structural damage, and then over time we see development of structural changes in the sacroiliac joints, and functionally, clinically more relevant also in the spine. Not in all patients, and that's why another picture would reflect the real situation here much better. What you see here is the proportion of patients over time, and if we talk about non-radiographic axial spondyloarthritis, so patients with early axial STA, at the beginning we see rather rapid progression, and the majority of patients who can progress, they do progress within the first 5 to 10 years from non-radiographic to radiographic, and in all other patients this process might take longer, and there are patients with axial spondyloarthritis who never develop definite structural changes in sacroiliac joints. And the same is also true for the spine, and nowadays we see only in a small proportion of patients significant structural damage, but it is quite relevant for patients, and therefore it is also important that our treatment strategies are also able to prevent structural damage in the spine. Let me present you a short case. This is a young male patient, 24 years old, with low back pain for about 1.5 years, with pain at night, morning statements of about 45 minutes, some improvement with exercise, no improvement with rest, no body pain. I hope you agree with me that all in all, this symptom complex is compatible with what we call inflammatory back pain. No other manifestations of spondyloarthritis, so in spinal mobility is normal, HbA1c is positive, and CRP is slightly elevated. So a patient profile where we can say, well, inflammatory back pain in a young male with VRA positivity in the CRP. So spondyloarthritis, inflammatory disease involving spine is quite probable, but we always try to confirm this objectively. We always try to find out if those inflammation or post-inflammatory changes in sacroiliac joints in the spine. So if we talk about primary axial spondyloarthritis, normally we focus in our initial approach on sacroiliac joints, and it is still recommended to perform X-rays of sacroiliac joints first, although we need to remember that X-ray of sacroiliac joints is not very sensitive, nor very specific. So in this case, we see that left side is kind of normal. On the right hand side, we see some so-called sclerosis, but no clear erosions, really few erosions there. And this is a clear case where we need cross-sectional imaging to confirm the presence of inflammatory disease in the axial skeleton. Ideally, this is MRI and MRI separated joints. If there is pain in another localization, then also another anatomical region, let's say thoracic spine, could be also performed. And this is an absolute minimum of what we need to judge on the presence of excess spondyloarthritis. We need to look at active inflammatory changes in a stir sequence or another T2 weighted sequence with fat suppression, and we need to look at structural changes on a T1 weighted sequence. What we are looking for is presence of vulnerable edema localized in typical anatomical area, ideally in combination with some structural lesions, and then if you see both active inflammatory changes and structural changes, like here, erosion here, you can be sure that this is excess spondyloarthritis. And then you can start treating the patient. In this case, we started as always with non-steroidal anti-inflammatory drugs, and after some time we saw, well, it is not working sufficiently, there are still symptoms, so that will be a question, what should be the next treatment step. Relief in a number of treated targets in difficult rheumatic diseases, including excess spondyloarthritis, and here I want to stress that treat to target is not a practical recommendation. It is a framework saying that we need to target remission, we need to put our patients in symptom and inflammation-free state, and we need to use standardized assessment methods to speak the same language. And for the assessment of disease activity in excess spondyloarthritis, currently ANSYS is recommended. What is the idea behind this? The idea is to prevent not only reversible disability related to inflammation, but also irreversible disability going through structural changes, and I think here is quite obvious, the earlier the better. Also, the depth of inflammation control is really important, and we target inactive disease or alternatively low disease activity in excess spondyloarthritis. However, if you are not in this area, that doesn't mean that you need automatically switch your treatment. Much more important is to check what is the reason for not achieving inactive disease or low disease activity, and this is the spirit of treat to target recommendations. I would like to briefly present you the current treatment paradigm, just recently updated by ANSYS to EULA, and what we have here, the major change to this recommendation was that in addition to non-steroidal anti-inflammatory drugs, TNF and IL-17 inhibitors, we have another drug class, JAK inhibitors, and we tried to adapt these recommendations to the new reality. Here, several phases of the treatment approach is reflected by this recommendation. So phase 1 remained more or less the same as we had it 5 and 10 years ago. Everything starts with a clinical diagnosis of excess spondyloarthritis, and if there are symptoms, we start with non-steroidal anti-inflammatory drugs. And these are very potent, very effective drugs, and the majority of patients with excess spondyloarthritis, they are doing well with NSAIDs, and normally they don't need to be taken on a regular basis at the day highest dose. You really need to advise patients to take as much as they need. And normally they need only NSAIDs in a situation of disease flare. If it works, it is great. If you control inflammatory activity and symptoms with NSAIDs, it is great. If not, you need to go to the second phase. And this phase is slightly different for patients with mainly peripheral and purely axial symptoms. So in peripheral symptoms, you can consider local steroids, and you can consider, so this is can, not must recommendation, you can consider superstats here. But normally, after NSAIDs, we go to the step of biological targeted synthetic DMARDs. As you see here, all 3 drug classes on this step are present here, but the current practice, and this is related mainly to efficacy, but also safety data, current practice is to start with biological disease-modifying anti-rheumatic drugs such as TNF or IL-17. What is new here in this recommendation set is the statement based on the data that different extramuscular skeletal manifestations might affect the choice of the drug. I will come to this in a second. And then final phase, if excess spondyloarthritis is not responding to the first line B or TXT mark, you need to re-evaluate the diagnosis or the reason of the back pain, and if inflammatory activity is confirmed, then you can switch within the class or to another drug class. So in the daily clinical practice, we quite often ask ourselves what would be the best treatment option for an individual patient sitting in front of me. And I need to say that if you look at data for the efficacy in the musculoskeletal domain and the axial domain, you see that all TNF-alpha blockers, they are quite effective, and they are still similarly effective in patients with ankylosing spondylitis. Also, if you look to the data for IL-17 inhibitors here, for example, sebekinumab, in anti-TNF-naive patients, you see that the efficacy of sebekinumab 150 falls exactly in the range we would have expected with TNF-alpha blockers, for example, is a sporting response between 40 and 48%. In patients with previous experience with TNF-alpha inhibitors, the response to active drug is always lower, but the same is also true for placebo. This is a more difficult patient population. We have nowadays possibility for treatment escalation in axial spondyloarthritis from 150 to 300 milligram. Normally we reserve this for patients who have been treated with TNF-alpha blockers or patients not responding to the 150 milligram dose sufficiently. And this is based on the results of this data. You see numerically better response to 300 in TNF-inadequate responders, but also higher probability of achieving as partial remission associated with higher dose. We have also other IL-17 blocking drugs, for example, here is sebekinumab. Again, if you look at here in the efficacy of IL-17 blockade and anti-TNF naive patient population, you see that this is exactly in the same range between 40 and 48, 49% with TNF-alpha blockers and with sebekinumab. We have here an active comparator arm, so you might think that the efficacy of IL-17 blockade is higher than of TNF-alpha blockade, but this is not the case for other endpoints. So we would say that today the efficacy of these drug classes is fairly the same. Recently, we received also check inhibitors for an indication axial spondyloarthritis. That was one of the motivating factors to revise others' dual recommendation set. And as you see here, again, clear delta between upadacitinib and placebo, but the efficacy doesn't seem to be higher as compared to data with biological disease-modifying anti-rheumatic drugs, and the same is also for tofacitinib. So the question here would be, can we do better than just 40 to 48% of INSIS 40 response? And the answer is clearly yes, if there are predictors of good treatment response. What are those predictors? Already at the beginning of anti-TNF era, we realized that patients with shorter sleeping duration, with elevated CRP, they are best candidates for good treatment response. Look at this upper line, red line, so patients achieving almost 100% of base 50 response. These are patients with short sleeping duration with elevated CRP and also positive MRI. If you look at this line, black line, these are patients with long-standing disease with low CRP, and if MRI also makes, then the probability of good response is very low. There are also several clinical studies showing that the probability of remission achievement is increasing with a short sleeping duration. For example, in this study, infliximab in the regular ankylosing spondylitis defined by short sleeping duration, you see that remission achievement rate was very high, and this was also true in another early axial spondyloarthritis study, in the INFA study, where you see very high response rates in terms of partial remission or past-inactive disease for the combination of infliximab with naproxen, but also for naproxen alone. What about non-radiographic axial spondyloarthritis? So non-radiographic axial spondyloarthritis is not automatically the same as early axial SPA, and this became very clear in recent times. So early axial SPA is always defined by time, but not necessarily by the fact that there is structural damage in subclavian joints or not. We saw in phase 3 trials with alpha blockers quite a heterogeneity of the response. But if you put patients in the same study with same level of inflammatory activity, with elevated CRP or positive MRI, then you can expect exactly the same response, irrespective of the presence of structural damage in supplemental joints visible on X-ray. And this is very important message, saying you that patients with radiographic and non-radiographic extraspondylarthritis, they belong to the same disease. We have nowadays also good data on the efficacy of 17 inhibitors, in this case, serotinib in patients with non-radiographic extraspondylarthritis. You see that was a study with very long placebo-controlled phase, but at both week 16 and week 52, serotinib was significantly superior to placebo in terms of achieving primary endpoint that was excluding response. Very similar results are also obtained for another IL-17 inhibitor, ixekizumab. But what you need to remember always for daily clinical practice, you really need to see objective signs of inflammatory activity if you diagnose patients with non-radiographic extraspondylarthritis or with extraspondylarthritis without structural changes on X-rays. If you have MRI positivity or CRP positivity, then you can expect good delta between active drug and placebo. If both are negative, then there is no difference between placebo and active drug. And the same was observed in several clinical trials. The same is also true here for golimumab, where you see the difference between active drug and placebo only in patients with at least one positive marker of inflammatory activity. And this we observed also in the post-hoc analysis of the previous studies of serotinib in non-radiographic XRSPA, where we saw a difference between active drug and placebo only in those patients where there was one marker of inflammatory activity, objective marker of inflammation. And this is also quite important, not to diagnose patients with inflammatory disease if you don't see any objective inflammatory activity. So if you look at the data for the musculoskeletal domain, you need to make this decision, then you can say that there are all these three drug classes affecting an extraspondylarthritis, but you need to consider local regulation, approval status, and look for objective information of inflammatory activity. About different facets of spondylarthritis, I promised to speak about this a little bit, and indeed we see different efficacy of different drug classes in different domains. In the era of monoclonal antibodies against TNF-alpha, we saw that they are all effective in all manifestations. Then we started to see some differences, for example, for IL-17 inhibitors, high efficacy in skin, but no efficacy in gut, and the same continued also with other drug classes. So this is quite important. This is stated now in the recommendation set. So if you have extraspondylarthritis with IBD or active acute anterior uveitis, the preference would go in the direction of monoclonal antibodies against TNF-alpha, and maybe in some cases you can use also JAK inhibitors. For the patients with extraspondylarthritis plus psoriasis, you need to consider IL-17 blockers, and don't forget, for JAK inhibitors, we have some safety issues, so you need to discuss it with the patient. You need to consider risk factors for cardiovascular disease in order to not to put patients at risk. In the final few minutes, I would like to talk a bit about structural damage as a long-term outcome of our treatment in patients with extraspondylarthritis. We learned that the first step in the development of structural damage is always inflammation, followed by rehab process, and finally these areas with repaired tissue, they give rise to new formation, to syndesmoid lines. There is a concept of window of opportunity for disease modification extraspondylarthritis, and this hypothesis says that if we have active inflammatory lesion, acute anterior spondylitis anterior, without any signs of structural damage, we are able to resolve this with any effective anti-inflammatory drug without subsequent new modification. If we have material lesion, with signs of structural changes there, with repair, we might see new formation even after complete resolution of inflammation. And that means practically that even if we start treatment in advanced disease, we still might see some response of reduction of structural damage progression, but we need to wait longer. And this has been shown in several studies, most recently also in the gastric problem. Here, we compare patients who received 10 millimeters in a given 2-year interval where we also look for the structural damage progression. And we saw no difference. But when we follow up patients for longer, for another 2 years, we suddenly start seeing the difference between year 2 and year 4, meaning that most of the drugs we are applying right now, they are able to control inflammation, and through this they are able to prevent structural damage progression, but we might need to wait a bit longer, meaning we need to control inflammatory activity on the long run. Here you see work summarizing structural data for different drug classes, and you see here also data for secukinumab, which suggested that there might be a low progression associated with IL-17 blockade that resulted in a hypothesis that with IL-17 blockade we might be able to prevent or to retard structural damage progression straight away, already within the first 2 years after treatment initiation, and finally this resulted into this clinical study. This is a very important study, the first real head-to-head study in axial spondyloarthritis, which compared the effect of secukinumab versus adalimumab biosimilar in active ankylosing spondylitis in terms of preventing or retarding structural damage progression. It was a really big study. We recruited a total of 859 patients randomized into one of these 3 arms, secukinumab 150, secukinumab 300, or adalimumab biosimilars, and all patients were followed up for 2 years with X-rays and MRIs. And I need to tell you, I read all the X-rays and MRIs within this study. That was quite an amount of work with all the endpoints, and all these patients were patients with quite severe and active disease. All patients had risk factors for structural damage progression, either positive CRP or positive MRI. Here you see the main results of this study. This is a cumulative probability plot showing the progression of structural damage over 2 years associated with secukinumab or adalimumab. And as you can see here, there was no big difference between all 3 treatment arms here. Is it a negative result or is it a positive result? I would say this is a positive result, because nowadays we know that TNF alpha inhibitors, they are able to prevent structural damage progression if you control inflammation. And the same result is observed also for secukinumab, meaning that there is no major difference between those 2 classes. So we can be confident if we give, let's say, an IL-17 inhibitor or another effective anti-inflammatory drug to a patient with ankylosing spondylitis, we can be sure that we will be able to prevent or to retard structural damage progression if we control inflammation continues. So my take-home messages here are we learned that remission, low disease activity is a primary treatment target in ankylosing spondylitis or axial spondyloarthritis in general, and treatment target concept is a management framework that doesn't apply phonetic treatment escalation if a predefined treatment target is not been reached. Objective confirmation of inflammatory disease nature, short symptom duration that are the best predictors of good treatment response. TNF IL-17 inhibitors are all effective drugs for patients who are not responding to NSAIDs, and you need to consider the presence of extramuscular skeletal manifestations, patient preference, but also safety aspects when we make a practical decision which drug to take. For structural damage progression, we learned that early, effective, and continuous, all 3 are important. So early, effective, and continuous inhibition of inflammation with any effective drug class would be sufficient to control also not only inflammatory activity but also structural damage, and the golden window remains quite a long time open, and this is true as well. There is inflammation in the spine and circular joints, but we need to remember that earlier treatment is associated always with a better outcome, meaning that our efforts to shorten the diagnostic delay, they are still in place and they should be continued. Thank you very much for your attention.
Chúng ta sẽ có một một vài câu hỏi. Từ đây là cái video các bạn đã phát ra và chúng ta đã nghe cái bài viêm khớp cột sống thể trục, và chúng ta đã biết là cái cửa sổ vàng trong điều trị thì chúng ta biết là càng điều trị sớm càng tốt, và những cái mà khi mà chúng ta để nó đã thời gian quá kéo dài, tình trạng viêm không còn nữa nhưng mà nó không đạt được cái hiệu quả. Và ông cho thấy rằng là tất cả các cái thuốc vì là hãng tên pha có trước thì đầu so sánh với cái loại Situmumab thì chúng ta thấy rằng là chúng ta có thể lựa chọn tất cả các loại nào chúng ta có sẵn và nó kết quả nó tương đương. Chúng ta có câu hỏi nào không ạ? Thầy Ân có câu hỏi. Vâng. Thì thực ra mà nói thì nói nhanh, thì có một câu hỏi đấy nhé. Xin mời dịch vụ này. Theo kinh nghiệm của giáo sư, nhóm bệnh nhân viêm khớp cột sống thể trục mà chưa có tổn thương trên X-quang đúng không? Bạn nào nói em biết các cái này là gì không, chưa đúng không? Loại nào có nguy cơ cao tiến triển viêm khớp cột sống, tức là chưa có tổn thương trên X-quang đúng không? Cái này là viêm khớp cột sống thể trục thôi. Chưa có tức là tóm lại là nhóm bệnh nhân mà viêm khớp cột sống thể trục mà chưa có tổn thương trên X-quang thì nhóm nào có nguy cơ cao để tiến triển thành viêm khớp cột sống hoặc là viêm cột sống dính khớp mà cần can thiệp sinh học sớm?
Yes, I can hear you.
Okay, the question is, in the populations of axial SPA non-radiographic, according to your experience, which patients at high risk, which can progress to AS or SPA?
Okay, good morning, dear colleagues. So the question is about progression from non-radiographic to radiographic axial spondyloarthritis, and I can tell you that there are several clearly identified risk factors for progression, and they include, first of all, high inflammatory activity, meaning if there is a lot of inflammation in the sacroiliac joints, high level of C-reactive protein, these would be the candidates, the patients with high risk of progression from non-radiographic to radiographic. Other factors include HLA-B27 positivity and male gender, but inflammation in sacroiliac joints is a leading factor. And to be honest, quite often we see a situation that patients with the highest risk of progression, so patients with very active sacroiliitis, they progress within several weeks or months. So when they approach us, they have already radiographic sacroiliitis, while patients with less active disease, they might stay non-radiographic for a longer time period.
Vâng, vì là nó không có thời gian nữa cho nên là chúng ta sẽ kết thúc bài của chúng ta tại đây và chúng ta sẽ chuyển sang bài khác. Vâng, thank you for your excellent presentation and good question, good answer. Thank you.
Thank you very much. Because we run out of time, so we will finish our Q&A session here. So thank you for your presentations and your presenting here.
Thank you.
Bye bye. And see you later.
See you.
Chúng ta sẽ chuyển sang bài sau, thì chúng ta cũng là một cái bài mà online ạ. Giáo sư Chandran, giám đốc đơn vị loãng xương và chuyển hóa xương của Bệnh viện Đa khoa Singapore, Chủ tịch Hiệp hội Loãng xương của châu Á Thái Bình Dương sẽ trình bày bài cập nhật điều trị loãng xương có yếu tố nguy cơ gãy xương cao.
Ciao, everyone. One second. Ciao, everyone. Can you see my slides? Yes. Okay. So, ciao, everyone. thank you so much to the Vietnam Rheumatology Association for inviting me to speak at this very prestigious conference. I have been tasked to speak on unmet medical needs, and I'll give you an updated management of osteoporosis in patients at high risk of fracture. I'm Dr. Manju Chandran, and I'm a senior consultant, and I direct the osteoporosis and bone metabolism unit at Singapore General Hospital in Singapore. I also chair the Asia Pacific Consortium on Osteoporosis, and we do have Vietnamese representatives from Vietnam in the Asia Pacific Consortium on Osteoporosis. So these are my disclosures. Okay, so this is something which I would like to point out to you. Now, David Marsh has called this as the osteoporotic career. Okay, so some women embark on an osteoporotic career, and when this career begins, could be different for different people. It could be somebody, a woman, she could be 50 when she has a wrist fracture. And then a few years later, she could present with a humerus or a pelvis or a vertebral fracture, and at the age of 60 or 70, she could then have a hip fracture. The point is, we are missing these opportunities for intervention. These are all opportunities for intervention which we are missing. The woman who presents at the age of 50 with a wrist fracture, we just cast her arm and sent her on her way. We really did not do anything. We did not start. We did not even assess her for osteoporosis. And then she comes back a few years later. Now she has got a pelvis or a vertebral fracture. We ignore that too. And then what happens at the age of 70 or 80? This poor lady then presents with a hip fracture. So the burden of osteoporosis and fragility fractures is huge. The problem is that we're not seeing the problem that is right in front of our faces, and we're not intervening when we should. So one fracture begets another fracture. So with that, let me introduce you to Madam BHB, Break Her Bones. She's 71 years old. She has a BMI of 19.3 kilogram per meter square. She has got quite a complicated medical history. She has got bronchiectasis, but thankfully it is not that bad. She is just coming back for annual follow-up. She has a hyperlipidemia. She takes simvastatin for it. Now, her osteoporosis was diagnosed way back in 2011. She was under primary care, and it was diagnosed after a fall and after she sustained a small metatarsal fracture at the time. And thankfully, somebody did order a bone density test. And so if you were to look at the progression of this person's bone density test from 2011 to 2022, you can see how her bone density has decreased significantly over the years from 2011, when her lowest T-score was minus 2.6 the total hip. And now, when we look at it, the progression, it has progressed. Now her lowest T-score is minus 3.5 in the lumbar spine. She's an ex-school teacher. She's quite independent, even though she's 71 years old. She's quite independent in her daily activities. And finally, she has come to you because they have known that you are an osteoporosis specialist, so they refer you this patient. And when you look at her, when you assess her, you find out that she has, though she was started on alendronic acid for her osteoporosis, she's been very non-compliant. She did take it continuously for 1 year when first started, but very irregularly thereafter. Alendronate, as you know, is given once a week. She has not been taking the medication at all in the last 5 years. So her fracture risk calculation turned out to be her major osteoporotic risk fracture was 16% and a hip fracture risk was 7.3%. So I'm going to ask you, what would your treatment plan for Madam Break Her Bones be? I'm sorry, the name was mistaken. It's Madam Break Her Bones. Would you restart the oral bisphosphonate? Would you switch her to intravenous bisphosphonate? Would you start her on denosumab? Would you start her on teriparatide? Or would you start her on romosozumab? Now we'll leave that here for a minute and we will come back to it after at the end of the presentation. So there is a plethora, there are multiple medications available to treat osteoporosis. from way back in 1984 when estrogen was first used, when hormone replacement therapy was introduced as a treatment of osteoporosis. We have come a very long way. So in between we had all the bisphosphonates. The first bisphosphonate to be used was etidronate, and subsequently 1995 alendronate was started to be used in osteoporosis. Then we moved on to selective estrogen receptor modulators such as raloxifene. Then in 2002 the first anabolic therapy for osteoporosis, teriparatide, was launched. Subsequently, strontium granulate came on the market, but pretty soon was taken off the market because of its cardiovascular risk. Zoledronic acid, the intravenous formulation of bisphosphonate, came into use in 2007. Subsequently, in 2010, denosumab, and then in 2017, the PTHRP analog, abaloparatide, and very recently in 2019, the sclerostin antibody inhibitor romosozumab was launched. So we have a plethora of medicines. We have so many medicines available to treat osteoporosis. The question is, how do we use them wisely in our patients with osteoporosis? And the FNIH trial has shown that improvements in BMD, all these medicines which help improve BMD will subsequently also help decrease the risk of fractures. So just briefly going through the anti-resorptive medications in the treatment of osteoporosis. Hormone replacement therapy, like I said, was launched in 1984, showed very good effect in reducing both vertebral and hip fractures. Some selective estrogen receptor modulators such as raloxifene, I'm not sure whether it's available in Vietnam, but raloxifene has been shown to very significantly decrease the risk of vertebral fractures. Then all the multiple bisphosphonates that you have from anywhere from alendronate to ricetonate to ibandronate to zoledronic acid, all of them have shown good reductions in vertebral and non-vertebral fracture risk reductions. And I will be concentrating mostly today on denosumab, which is a RANK ligand inhibitor, and the study which I'll be focusing on is the Freedom trial. So denosumab is a RANK ligand inhibitor. So just stepping back a little bit to talk about just a little bit about basic science, RANK ligand, or receptor activator of nuclear factor kappa B ligand, is a member of the TNF receptor family. Now it's produced by the osteoblast. What it does is RANK ligand binds to the RANK on osteoclast and causes differentiation and activation of these cells. Now what OPG or osteoprotectin does is that it acts as a decoy receptor for RANK ligand and prevents RANK ligand from binding to RANK and causing osteoclastic activation. So if you have something which inhibits RANK ligand, then that can inhibit osteoclastic differentiation and thereby decrease osteoclastic bone resorption, and thereby can be used as a treatment of osteoporosis. Now, OPG, like I said, is a naturally occurring endogenous RANK ligand inhibitor. Denosumab is a human monoclonal antibody to RANK ligand. What it does is it binds RANK ligand and inhibits RANK ligand action and thereby inhibits osteoclastic bone resorption. So I'm just going to, like I said, I'm just going to focus on one particular study of denosumab. There are several other selected phase 2 and phase 3 studies on denosumab, but I'll just concentrate a little bit on the Freedom trial, which is the pivotal trial for denosumab. Now the Freedom trial stands for Fracture Reduction Evaluation of denosumab in Osteoporosis every 6 months. It's a phase 3 randomized controlled trial. It was in postmenopausal women with baseline T-scores between -2, that is less than -2 but better than -4. And they were randomized to either denosumab 60 milligrams subcutaneously once in 6 months or placebo, and the trial, the original Freedom trial was for 36 months, it is for 3 years. The primary endpoint were new vertebral morphometric fractures. And what was shown was that very clearly there was a significant reduction in vertebral fracture risk reduction with denosumab, and there was also a significant reduction in non-vertebral fracture risk as well as hip fracture risk with the use of denosumab. Freedom trial was extended over for a total of 10 years, though after 3 years there was no placebo, and continued, over the next 7 years, continued effect of denosumab was seen in decreasing both vertebral fractures as well as non-vertebral fractures with, increasing BMD. Now, unlike bisphosphonates, which cause an increase in BMD in the first few years, but after that there is a plateauing. Denosumab continues to increase BMD at both the lumbar spine as well as the hip, and this increase in BMD seems to be associated with a decrease in fracture risk, both vertebral and non-vertebral, over 10 years of treatment with denosumab. So, this is to show that what it does seem to say that once with the increase in BMD with denosumab is associated with decrease in fracture risk, and a lower incidence of fractures was noted with higher T-scores. So people who attain higher T-scores with denosumab therapy seem to have a lower incidence of fractures. And so this actually was the basis for the concept of a treat to target in osteoporosis. That is, can we reach a target BMD T-score for osteoporosis? Came with this finding from the denosumab extension studies in which a lower incidence of fractures was noted with higher T-scores. Now, the one problem with the concern which some of you may have with denosumab therapy is that you might have read or you might have experienced that there is a significant increase in rebound vertebral fracture risk after discontinuation of denosumab. Now, in the post-hoc analysis of the Freedom and the Freedom Extension trial, in women who stopped denosumab or placebo and were followed for 9 to 12 months after the last denosumab or placebo injection, the annualized risk of vertebral fractures was the same. Whether it was denosumab or whether it was placebo, the annual incidence of vertebral fractures in women who stopped denosumab or placebo was the same. However, the proportion of women with vertebral fractures who experience multiple vertebral fractures was larger amongst those who discontinued denosumab compared to placebo. So it appears that the effects of denosumab are very temporary. If you stop denosumab treatment, then there is a rebound increase in possibly bone turnover. We don't really know the reason why exactly there is an increase in this risk of vertebral fractures, multiple vertebral fractures. Several theories have been postulated, whether it is due to an increase in bone turnover, the suppressed osteoclasts which were dormant during denosumab therapy, whether they are rebounding, whether there is an alteration in the rank ligand OPG ratio, etc. We really don't know the reason why, but there definitely clearly seems to be an increase in the risk of multiple vertebral fractures after discontinuation of denosumab. So this is obviously a concern. Denosumab has shown great success in reducing risk of vertebral and non-vertebral fractures, and we have clearly showed that increase in BMD is associated with a decrease in fractures. But how long you treat it with, and when you stop it, whether this risk of vertebral fractures can happen. And people have looked at what to do after stopping denosumab. What do you switch the patient to? There is data with both starting bisphosphonates after stopping denosumab. Raloxifene has been tried, but the unfortunate thing is that even treatment with zoledronic acid, which is a potent anti-resorptive, irrespective of the timing after denosumab discontinuation, did not fully prevent loss of BMD in patients discontinuing denosumab. So this whether zoledronic acid was started 6 months after the last denosumab dose, or whether it was started 9 months after the last denosumab dose, or whether it was started when the bone turnover markers started increasing again, they really zoledronic acid did not completely reverse the bone loss in patients discontinuing denosumab. But still, it did decrease it. It's just that it did not completely prevent. So there is ECTS, the European Calcified Tissue Society. They have come up with recommendations on what to do in people after they've stopped or after you've discontinued them from denosumab. So the bottom line is that in young patients with low risk of fracture, in general, denosumab treatment is generally not recommended because, say for instance, in a 50-year-old woman who was just found to have osteoporosis on a DEXA scan, I probably would not start on denosumab, because you're looking at years and years of therapy, and how long will you treat, and when can you stop? Now, if the person has been on denosumab only for a short period, that is for less than 2.5 years, and the person has got low fracture risk, I would probably switch to oral bisphosphonates for 12 to 24 months, or administer IV zoledronic acid for 12 to 24 months. Now, suppose the person has been taking denosumab for a long time, more than 2.5 years, or the person has got high fracture risk, I would just continue the patient on denosumab. For up to 10 years, we have safety data, but I have some patients on who I continue it even afterwards. But if you really feel worried and you want to take the person off denosumab, you do again switch to zoledronic acid, but you would give the zoledronic acid 6 months after the last denosumab injection and measure bone turnover markers 3 and 6 months later. And sometimes in some of these people, they might require another infusion of zoledronic acid if the bone turnover markers are persistently increased. If the zoledronic acid is not an option due to availability issues, maybe zoledronic acid is not available everywhere, or the person cannot take IV zoledronic acid, treat with oral bisphosphonates for 12 to 24 months. And this is in persons who you are taking off of denosumab. So now we talk about side effects, right? Potential side effects and the concerns of atypical being of fracture with denosumab and osteonecrosis of the jaw. The FREEDOM trial, the first 3 years, there was no incidence of ONJ or atypical fractures noted. But what about if you continue denosumab for long term? Now the FREEDOM extension trial, really there was no placebo, right? It was not a randomized controlled trial. It was just an observational trial of continuing denosumab. So Whittinghoff and his group, and there are other people, Socrates, Papadopoulos, and all that looked at this, and they came up with this what's called virtual twin approach, in which, because there was a lack of a long-term placebo group, a hypothetical or a virtual placebo group was created. And this has been used before, even in the alumni trials, as virtual twin approach, which makes up for the fact that there is no real placebo. A virtual placebo group is created, and this has been previously used for trials with bisphosphonates. The same approach was used for denosumab, and what was seen was that when you look at the 10-year extension in the virtual placebo group of both fractures as well as skeletal adverse events in the long-term denosumab and virtual placebo groups, when you look at the skeletal benefit versus risk ratio, 281 clinical fractures were prevented for one atypical fracture of the femur, and 40 clinical fractures were prevented for one osteonecrosis of the jaw. So the skeletal benefit risk ratio seems to favor the use of denosumab. Now, this was talking about people at high risk. Now, I do want to end my talk with a very brief introduction to the concept of very high fracture risk. Now, what is very high fracture risk? So, some groups like the American Association of Clinical Endocrinologists, the Endocrine Society, etc., have interpreted very high fracture risk on a basis of a combination of risk factors. Say, for instance, the person has had multiple fractures, if the person has had very low T-score, less than -3, or the person has had a fracture within the past 1 year, or in the US, for instance, where the fracture probability is very high. So that is how the US people, the US societies have categorized very high fracture risk. On the other hand, IOF and the SKO, the European people, the Europeans have actually looked at what is an age-dependent kind of frac space threshold, and what they categorize as very high risk is in this category. And for instance, there is high imminent risk of a second fracture within the first 2 years of an index fracture. So the concept of a very high fracture risk should probably be individualized, and each country should probably develop its own concept of what is high risk and what is very high fracture risk. So, and what do you do with these people with very high fracture risk? Now the AACE guidelines, the American Association of Clinical Endocrinologists for Managing Postmenopausal Osteoporosis, like I said, they consider people with very high fracture risk as somebody who's had a fracture within the last 12 months, who's had multiple fractures while on therapy, BMDT score which is very low, which is less than -3, etc. And in that very high fracture risk group, in fact, they are recommending that an anabolic treatment be instituted first, such as teriparatide, abaloparatide, which is a PTHRP analog, or romosozumab. And in the high-risk group, which there's some previous hip or spine fractures, which is more than 12 months ago and all that, any of these agents can be used, bisphosphonates, denosumab, etc. And this is the IOF STO guidelines. They also suggest that in the very high fracture risk, maybe an anabolic agent should be considered first, followed by an anti-resorptive agent. This is just to bring up the concept of very high fracture risk, and I end my talk with just a brief mention of a couple of the anabolic therapies that we have available. We have the PTH analog teriparatide, which has shown both reduction in new vertebral fractures as well as non-vertebral fractures. The original study was terminated early due to toxicology studies in rodents showing osteosarcoma risk, and therefore we really do not know whether teriparatide can prevent, hip fractures. There shouldn't be any reason why it shouldn't. But that's one anabolic therapy. And the second anabolic therapy, which I would just like to briefly introduce for people who are not familiar with it, is romosozumab, which is a sclerostin monoclonal antibody. And sclerostin monoclonal antibody romosozumab, the pivotal trial with it was the FRAME study, the fracture study in postmenopausal osteoporosis, were assigned to either romosozumab. Romosozumab is given as an injection subcutaneously once monthly, or placebo for 1 year, followed by 1 year of open label denosumab. And the primary endpoint was the cumulative incidence of new vertebral fractures at 12 and 24 months. And what it did show was that there was a significant reduction in the incidence of new vertebral fractures, both at 12 months with romosozumab, and then at 24 months when romosozumab was followed by denosumab. This laid the concept of this very important concept called the foundation effect, which means that you rebuild bone in patients with severe osteoporosis with an anabolic therapy first, followed by an anti-resorptive agent, and this is known as the foundation effect. You build a strong foundation with an anabolic agent, then you switch over to an anti-resorptive agent such as denosumab. So in summary, for moderate to high-risk patients, you could consider sequential use of anti-resorptive agents. You could, in postmenopausal women for up to 5 to 10 years, you could probably use estrogens, but no longer than 10 years. Raloxifene, which is a selective estrogen receptor modulator, knowing that it has not shown data in decreasing non-vertebral fracture risk, it has shown data to decrease vertebral fractures, can also be used. Denosumab is a very good agent, or bisphosphonates, from mid-60s to elderly, but there's no contraindication to starting early. It's just that, like I said, I would prefer probably giving denosumab in the high-risk patients. Now, who should be considered for initial treatment? Anabolic agents, like I said, with a very high fracture risk. If you have anabolic therapy available, then probably you should consider using it in these patients who are at very high imminent risk of fracture, who have had multiple fractures in the past, or who have had a recent fracture in the past 1 to 2 years, or patients with very low bone mass, because in this group of people you want to improve BMP as quickly and as much as possible to reduce the risk of fracture. So if we go back to our original Madam Rekha Boards, probably I would consider her as a high-risk patient, and that's a patient in whom probably I would, she's taken bisphosphonates for a year, oral bisphosphonates for a year, she was very non-compliant with it. I would probably consider restarting her on either denosumab or even probably an IV bisphosphonate. I would lump her into the high-risk fracture group. So with that, Carmen and Baki Kohai. Thank you very much. And this is just to show you our APCO, our Asia Pacific Consortium on Osteoporosis. Please feel free to go to the APCO website. It's www.apcobonehealth.org. We have 53 members from 21 countries and regions in the Asia Pacific right now. So Carmen, and I'm happy to take any questions. Baki Kohoi.
Yes, thank you very much for your very interesting presentation, Professor Mandara. And now we move to the question and answer session because we don't have much time. So maybe one question from our audiences and colleagues. Is there any question raised?
Vâng, trong lúc mà mọi người có cái câu hỏi thì tôi muốn hỏi bác một câu là đây là một cái thuốc mà giống như là cái kháng thể đơn dòng, cho nên là liệu mình có phải có quy trình tầm soát như là khi mình làm các phương pháp của điều trị sinh học hay không? Ví dụ như là mình phải làm về lao hay không, phải làm về nhiễm virus hay không, vân vân.
So the question for you is that SPA will run antibody. So do we need to screen for multilateral tuberculosis or HSPC as we currently screen before biological treatment is parastasis and SPA?
Okay, very interesting question. No, actually, so when denosumab was first launched, there were concerns whether it would be associated with an increased risk of infections, being a monoclonal antibody. But no, those initial concerns about potential infections in these patients have been put to rest. So no, we do not screen for any of those infections before starting denosumab, and there have been no reports of any of those infections happening with denosumab treatment. There is a slightly increased risk of urinary tract infections noted. So personally, in my practice, I do not give it to people with multiple urinary tract infections in the last 1 year, or whether if they had like bad cellulitis, etc., or eczema and all that, I do not give denosumab. But otherwise, no. There is no concerns of major infections, and nobody screens for mycobacterial tuberculosis or hepatitis, etc., before starting denosumab.
Vâng, rất là cảm ơn bà vì có những cái bài rất là tuyệt vời và có những cái câu trả lời rất là thú vị, và chúng ta có lẽ là vì chúng ta hết giờ rồi cho nên chúng ta sẽ kết thúc cái phiên này đây và chúng tôi sẽ chuyển sang cái phần tổng kết của cái phiên này.
Thank you very much for interesting presentation and your wonderful answer.
Vâng.